everyone. Thank you, Christine. Thank you, everyone. Nice to see some other Seattle people here. So my name is Omid Bagheri Garakani, he, him pronouns, public health worker, nerd, organizer based in Seattle, Washington. I'm calling from Coast Salish land in Chief Seattle City. Institutional affiliations, Christine mentioned University of Washington School of Public Health. Also affiliated with the Washington State Department of Health. And yeah, co-author of the Abolition, Policing, and Incarceration Statements. And just first of all, thank you for being here. Thank you for having me. I'm really honored to be here today with you all on this panel. And feeling really privileged to kick us off. So hopefully I get to just tee up the comments from others. So I'm looking forward to listening and hearing from them as well. And checking in today, I'm sitting with the topic that we have about abolition, about public health, and just naming that I'm holding a lot right now on September 8th, 2022, thinking about how the police violence and state violence that we all know intimately well in the United States is connected to the police violence and state violence that's taking place in Iran right now, where Iranian women, Iranian people are fighting for their right, their human rights, their right to choose what to do with their own bodies, and so much more that is cumulative over decades of state violence in Iran. So first off, if you are not aware, please read on the videos and articles that are coming out, and find the nuance of how what we're seeing there is harm through the state violence, and the harm and the murder of Mahsa Amini, a 22-year-old woman who was killed by the quote-unquote morality police in Iran. I share all that because, again, one, that's what I'm holding today with you all, but also for us to then think about how all of these interconnections, how all this political, social, and historical context connects to, again, with my public health hat on, with and I affectionately call myself a public health nerd, how all these things are interconnected. And I think it invites us to understand what our work is as public health workers, or anyone who is ultimately looking out for the health and well-being of ourselves and our communities. One thing I often say is, and we, everyone here is a public health student or affiliated with a university of some kind, myself included. And whether or not we have degrees next to our name, or we go through a academic institution, remembering that those who are fighting for justice are also fighting for health. We cannot have a healthy community without a justice present, and vice versa. And so, I consider myself a lifelong learner. I came to the US when I was young. And so the interconnections between US imperialism, colonialism, and police violence and ICE in the streets of Black and Brown communities and immigrant communities here in the United States, again, connects abroad as well, connects to occupied Palestine as well. And so our work does not operate independently of injustice. We have work to do because of it. And, thinking about how capitalism, racialized capitalism also intersects with our health work, we know that public health, is not the priority. And if we are to build alignment and organize ourselves to first put health over everything, then that is one way we can understand abolition in particular as a public health strategy. This might be a newer term in public health spaces, but again, it's been the scholarship, the leadership, the strategies, are rooted in communities who have been for generations dealing and experiencing with the ways our institutions are designed to target and harm them, specifically Black communities and specifically Black women. I give thanks, and we all give thanks for their scholarship. And so I open with a quote. It's my favorite quote. And I hope it's not the first time you hear it today or in future sessions. And it's a quote from Dr. Ruth Wilson Gilmore about abolition is about presence, not absence. It is about building life-affirming institutions. That quote immediately struck me when I first heard it on multiple different levels, but one of them is because for me, and each of us we'll always check in with ourselves about why we are interested in doing public health work, why we're interested in going to getting our degree in public health, et cetera. When I heard that quote, I thought to myself, that's what I believe the work public health is as well. Public health is also about building life-affirming institutions, designing society in ways where people have what they need to be healthy, to thrive, and not just survive, or put up with what is generations since time immemorial harm to Black, Brown, Indigenous communities, all communities that are structurally marginalized. So if we truly invested in building that healthy community, then we must understand too that we cannot incarcerate our way to a healthy community, cannot police our way to public health. Public health is one of its tenets is about prevention, and so is abolition. So with the time I have left, I really want to talk about the work around the two APHA policy statements that if you haven't seen or hasn't been sent to you, I'm sure it will soon. But these two policy statements, the first one focused on law enforcement violence and the second one on incarceration, both were rooted and developed with the abolitionist framing and scholarship in mind. And want to quickly point out one thing for each of them. And then I hope to be around for Q&A if folks have other questions. But the policing statement, it passed in 2018 after 3 attempts through the American Public Health Association to adopt it. Every step of the way, it was given a negative assessment. It was categorized as anti-police, not aligned with public health, ironically, and many other things. But we persisted, and we knew that the goal, in fact, wasn't to actually get it adopted. The goal was to increase visibility and create more movement-minded public health workers, especially around the harms of police violence, which anything that harms health is within the scope and domain of public health. We wrote that statement at a time where the uprisings in 2020 after George Floyd and Breonna Taylor and others were killed, were not, that ripple effect that had not occurred yet. So the word abolition was more foreign. We wrote it without using the word, and it still got a negative responses every step of the way. We also got it adopted after 3 years. Flash forward to the incarceration statement that passed last year, 2021. Last couple of years are a blur. That statement passed, and because of the political moment that folks on the ground, community organizers all across the country and the world opened around the harms of policing and incarceration, it also was important for us as public health workers to not only do a policy resolution on the health harms of incarceration, but also explicitly name how abolition and public health are interconnected and synonymous. Oh, that's my own timer or someone else's timer. So I'll quickly wrap up and say that we also face resistance even using the word abolition with the incarceration statement, and it also passed. And the primary reason both of them passed, and they ultimately both passed with overwhelming support, in fact, is because everything within is soundly public health. It was undeniable. It was objectively solutions and strategies that public health workers can amplify, that community is already doing, and that public health workers can implement to support community and these strategies being further implemented. All of it were evidence-based, all of it was soundly public health, it was undeniable. And so I guess I leave, my final thought is that if we're doing abolition work, if we're doing justice work, health justice work, wherever we're doing, make it undeniable, because there's nothing that can be said if we are putting the health and well-being of ourselves and others first. That is our primary call as public health workers. And I think that's how abolition and public health is always going to be intertwined. And so it is for us to keep learning, growing, staying connected to the community, finding the movement where we can plug in to kind of amplify and support that work. I will pause there.
Omid, appreciate it. Up next, we have Michael Mauney.
Good afternoon, ladies and gentlemen. It is an honor to be speaking to this network today. As Christine mentioned, my name is Michael Lewis Mauney II. I'm 43 years of age, and I've been incarcerated for 21 years. During this incarceration, I have become the proud graduate of the Boston University Prison Education Program with magna cum laude honors, earning a bachelor's degree concentrating on the history of political science. Also, I'm an avid organizer for DeeperThanWater, the African American Coalition Committee, the Harvard Prison Divestment Campaign, a restorative justice facilitator, and I'm currently pursuing a paralegal certification. Today, I've been tasked with providing y'all with experiences impacting health since being incarcerated and how it's connected to abolition. On February 15th, 2019, at the age of 40, I suffered a heart attack. Heart disease is something that runs in my family, but this was when I found out about that. While experiencing chest pain for upward towards 30 minutes, I was untreated by medical staff and correction officers after being given an EKG on a broken machine. A nurse practitioner that had regularly treated me for years intervened and told them, this individual is very articulate. If he can't explain what's going on with him, you might want to call 911. Long story short, if not for Kay, the nurse practitioner, I may not be here today to speak with you. Incompetence and medical neglect remain common even today, especially when dealing with for-profit companies like WellPath and people that have no checks and balances weighed against them. I would like to share some information that I came across that you must know. The following letter was written to the warden of MCI Norfolk, the commissioner of Massachusetts Department of Correction, and the director of DOC Health Services. And it was written on April the 15th. And it says, on February 28th, 2022, members of the Criminal Justice Reform Caucus visited the Clinical Stabilization Unit at MCI Norfolk. Following a tour of the facility and conversation with prisoners, staff, healthcare providers, and management, members of the caucus expressed a shared concern about the conditions of confinement and treatment of incarcerated individuals within the unit. As members of the Massachusetts General Court, we are committed to upholding the health, safety, and human rights of people incarcerated with Massachusetts correctional facilities, many of whom are constituents of our districts. As such, we want to share the following alarming observations that were brought to our attention during our visit at MCI Norfolk. The CSU's physical facility is outdated, unhygienic, disorganized, and overcrowded. Most of the incarcerated men are in their 70s and 80s, and the setting does not allow for adequate personal space for people who require, at a minimum, assistance with activities of daily living, and some of whom likely need skilled nursing care. There is an absence of privacy for the incarcerated men. Their medication, food, personal items are all stored in open spaces for anyone to see. Additionally, CSU residents have expressed privately concerns in the context of bedside medical visits where correctional officers often escort medical staff. Per information from some of the incarcerated men, we learned that nurses do not spend much time monitoring the CSU and often congregate on a separate floor to conduct their own conversations among themselves. Similar behavior was observed during our visit, as many of the legislators noticed the nurses and employees of WellPath remaining behind the plexiglass lined station room. We have received reports that the medical doctor is not on site as often as necessary for the incarcerated men, with reports of the doctor being physically present very briefly. Despite the CSU being one of the few hospital units in the entire Department of Correction prisons, a medical doctor employed by WellPath is only in the CSU from 9 a.m. to 5 p.m. Monday through Friday. The solarium where incarcerated men were isolated if they showed symptoms of COVID-19 is too close in proximity to the general CSU facility, and incarcerated men who tested negative for COVID-19 are inadequately shielded from incarcerated men who tested positive. In addition, while the solarium facility is more recently renovated, several incarcerated men informed us that during isolation, prisoners in the solarium did not have access to bathroom facilities, food, or running water. Legislators provided the DOC and MCI Norfolk senior staff with a 12-hour notice prior to visiting the CSU. The conversations with various incarcerated men in the unit, we learned that the staff at MCI Norfolk took advantage of this time, using it to scrub and clean the unit thoroughly. What legislators witnessed in terms of order and cleanliness was disturbing. We also were informed that in preparation of our visit, WellPath ensured more nurses to be present in the CSU than is typical. We share these observations and concerns with you in hopes of ensuring that moving forward, DPH and CDC guidelines are more clearly adhered to as implemented. We offer the following recommendations to address the urgent issue: improving overall transparency in the DOC through improvements in data collection and analysis. This involves identification, publication of demographics of individuals in Massachusetts criminal justice system, including race, ethnicity, gender, and age. Additionally, this would include increasing access to investigative journalists to observe and report on correctional facilities such as MCI Norfolk themselves. 2, require additional medical staffing, including an MD on call at all times, as well as more frequent visits to the CSU and other infirmary units. This would also entail incorporating a greater number of providers. Medical parole decarceration. Review all individuals in the CSU for medical parole eligibility and immediately file medical parole petitions for any individual who is available for medical parole. Initiate guardianship proceedings for individuals whose cognitive impairments necessitate the appointment of a guardian. Review those who might qualify for medical parole to see who should be released pursuant to decarceration budget language. Adhering to more robust sanitation practices. This includes routine cleaning, especially of areas such as bathrooms that are common sites for contamination. We urge the DOC to conduct an ongoing assessment of risk for the spread of communicable diseases and ensure that incarcerated sanitation workers have access to effective disinfecting equipment, appropriate PPE, and bins for hazardous waste. Ensuring that medical diets are strictly adhered to by food services. This involves making dietary supplements ready available for those who need it. Holding WellPath more accountable by creating sanctions for non-compliance with contractual obligations and requiring training for medical and correctional staff, as well as companions on medical and mental health and cognitive issues among the CSU resident population, including dementia. So I felt it very necessary for everyone to know that when you hear someone incarcerated complaining about their health being the fundamental human right that we all deserve, is the biggest public health point that is connected for us to be able to live long and productive lives, and the state is in charge of taking care of that. When they don't take care of us, it's so upsetting to me, like to know that the DOC is allowed to treat us and dehumanize us in a way that a lot of people don't know about. And being as being abolitionists, we're kind of tasked with bringing situations like this to light so that other people know what's going on, so we can try to decarcerate the prison populations, not only in Massachusetts but throughout the country. I have one thing that I want to read, and I got 3 minutes to do it. But this was a grievance that was sent out on April the 27th, right after the legislators came. It says, on April 24th, while working as a companion in the CSU, I was directed by a well-paid contracted staffer to perform actions that should I have followed them would have put another prisoner at risk of serious, potentially life-threatening harm. A fact that the staffer should have well known. The threat was so imminent that a senior DOC officer intervened to protect the other prisoner. On April 22nd, an elderly patient from general population was admitted to the CSU for observation after falling while walking. On April the 23rd, a CSU nurse assessed the patient to see if he could return to general population. The patient could walk, but he was presented with an unsteady walk. He also demonstrated some signs of confusion. The nurse determined that the elderly patient should remain in the CSU until further notice. On April 24th, it was clear that the patient's condition had declined significantly. He no longer could walk, even with a walker. He also soiled himself more than once, and he demonstrated unusual actions such as removing all of his clothes and sitting on his bed. At about 4 p.m., the patient again soiled himself while resting in bed. I assisted the patient to a wheelchair so I could help him to the bathroom before another companion could assist him to the shower. The nurse, a well-paid contracted nurse, came out of the nurse's station when she saw me wheeling this patient in the wheelchair. She abrasively asked me what I was doing. When I explained I was helping the patient to the bathroom, the nurse directed me to stop doing so. She scolded me by saying he can't walk and don't help him. I protested and stated that the patient could not walk. I also said that I was not going to allow the patient to hurt themselves. The nurse continued to insist that I had forced the man to walk on his own. When I placed a walker in front of the wheelchair, the patient struggled just to stand. I reached out to support the patient, and the nurse again demanded, "Don't help him." The patient fell back into the wheelchair. At this point, a lieutenant who was in the unit and heard the entire exchange intervened. He told the nurse that he had been the one who had placed the patient in the CSU. The lieutenant also said that he was very familiar with the patient and was aware of his condition and had deteriorated over the last day. The lieutenant directed me to carry on with my assistance, so I helped the patient. Subsequently, the nurse left the unit and was replaced by another nurse. Later during that same shift, it was determined that the patient's condition had further deteriorated and he was sent out 911. As of filing, the patient has not returned. It was reported that this particular person suffered from a stroke during this whole entire procedure, and they wanted to lock the guy that was trying to help him up, but the lieutenant stopped. So I just wanted to let everybody know that this is some of the things that are going on behind these walls that deal with public health, and I yield my time to the next speaker. Thank you.
Thank you, Country. Thanks for sharing all of that, and yeah, giving us a glimpse, just a small glimpse into the horrific treatment behind those walls. That was a lot. Just give y'all a second to reground, take a deep breath. And then I'm going to pass it off to Dr. Lopez.
Yeah, hello everyone. Thanks so much, Christine, and everyone else who organized this great event. And it's just so wonderful to see so many students come together to talk about this theme. I graduated from UT Health Science Center in Houston, and I see two people representing that school. That's not common that I see multiple people from UT Health Science Center Houston. So shout out to my alma mater. Got my master's there. And then came up to U of M and got my PhD here at the University of Michigan and continued to teach in the School of Public Health as a professor. 5 of us, wow, all right. Shout out to my Houstonians and everybody currently living in Houston there. So I do a lot of teaching about public health, many different topics, health communication, social determinants of health, other general topics that we learn and teach in public health. And I also have an immigration enforcement health class, which later transitioned to be called a law enforcement and health class. So I feel very fortunate that I've been able to have these different types of classes in which I can find the right way for ideas about abolition to enter into them. And I'll talk a little bit about that in a moment. I want to start with just a story about one of my friends. So his name was Hipólito Barajas. I have to remember his last name, but Barajas. And I met him because I was volunteering with this organization many of you might be familiar with, Black and Pink Milwaukee in this case. And the lead organizer volunteer, Kara, who's an EPID student at U of M, said, well, Bill, we need somebody who speaks Spanish. Are you able to speak Spanish? This individual needs someone to talk to, and he might get deported. He has a lot to say, a lot to talk about, a lot to process. I said, okay, that's something I can do. So we began to exchange many letters. He told me about his family. I told him about mine. He drew me pictures of what his room looked like, right, and what his situation was. And as happens, I was delayed in writing back. I sent a few of the books that he asked for later than I had wanted. I regretted that, and then I got a letter back. And for those of you familiar with what this looks like, right? So you get this letter back that says return to sender. Individual, in this case, this is inmate, not here. Right, so I was kind of torn up about this for obvious reasons. For those of you who worked pen paling or in these systems, you know that not here can mean a few things. And one of them, when working with someone detained, can mean they were deported, right? And this is not the first time that's happened where someone we are writing letters to has been deported and the letter gets sent back and they're no longer there. So I checked in with Kara, the individual who put me in touch with him, and we checked in with his lawyer, and his lawyer said, actually, he was released. So I want to take a second and kind of celebrate one person in a system of incarceration, but one person nonetheless, at a moment that turned into a very joyous one, right? Celebrating his release. And was also able to, and also the lawyer also told us, thanks for the letter that you wrote and the organizing you did, because we were able to write a letter on behalf of him discussing his challenges and from a public health perspective, right? So I've done this quite a few times, writing a statement to give to judges. This is what prison, in my case, this is what deportation looks like and what it'll do to someone. So I share this story, one, because it's a good summary of how I came to and how I found this work, right? How I find this work. It's deeply, deeply personal and deeply emotional for reasons that I believe all public health work is and should be intimate and emotional, right? We're studying people, we're studying death, we're studying suffering, we're studying illness, and we're studying the systems that cause it, right? But nonetheless, as we study these large systems of violence, every once in a while, there's victories, and there's victories that are deeply personal that we should continue to celebrate. But the other reason I really like to bring this case up is because one of the things I've learned, I've been lucky enough to work in abolitionist spaces, and I didn't begin there, so I want to tell you in a second how I arrived here, is that sometimes I don't have any idea what I'm going to do or where we're going to explore or what solutions we're going to find. And as an academic, many of you are, what we're trained to do is propose a project, propose why it's useful, and then propose exactly the solution that we're going to work toward. I'm going to do this and I'm going to disseminate this in these places, right? But sometimes I don't have any clue what I'm about to do. What many of us are, I don't know what we're kind of systems and the organizing that we're going to get ourselves into, and we don't know what's needed, right? And so we do this together. We bravely move forward into a space that We may not know where we're needed and what we're going to do, but it takes courage, and it's a community that allows us to do that. Um, the other reason that I really like sharing this story is because it does kind of illustrate how I came into the anti-incarceration, the abolition space. So as Christine mentioned, I wrote the book Separated: Family and Community in the Aftermath of an Immigration Raid. That follows a raid that happened 7 miles from where I'm sitting now. It's actually closer than that in my case because I'm closer than the university. So about 5 miles from where I'm sitting now. Right, this is my own Washtenaw County community, my own Washtenaw County Latino community. This was a fairly big raid in terms of raids in the Midwest, right? ICE collaborated with the police in this case, raided this apartment and took out all the men, leaving behind women and children, which isn't atypical in these situations. And while I was doing that work, I decided it was also important to figure out how police were contributing to the deportation system, right? So in interactions with police and field work and in event spaces in which I listened to and took notes on what police discussed and engaged in ride-alongs with them, they actually didn't want to talk about deportation and didn't even think it was something they were contributing to, right? What they wanted to talk about was the growth of the Black Lives Matter movement, though they did not use that phrase at the time because this was back near when Eric Gardner and others were killed. So police talked about all of these reasons, right? That we shouldn't be so, you all know, right? So hard on them in the media, et cetera, or whatever. But lots of the language they were using to justify the violence against Black men and women, including Ora Rosser in Washtenaw County, Black men and women and boys and girls, was the same language we would see when we're engaging when the system is engaging in deportation and arrest, right? So it followed a simple formula: make everyone believe that person is a villain, make everyone believe that person's dangerous, train, arm ourselves so that every solution has to come through force because that's all we know how to do. And so through this understanding of how the police were using this language, I started working more in the incarceration spaces and came to observe a few things that I see others bring up and that I'll bring up a bit today. And one is that in many spaces, the deportation and incarceration are often thought of separately, right? So it's thought of as this deportation system that removes people in this incarceration system that incarcerates people who live in the country and will ultimately, ideally, right, be released back into the US, but not removed. But many of us know that this is not the case, right? Similarly, we think in terms of policing and incarceration as an often African-American community issue, and deportation as a Latino community issue. We also know this is not the case, right? Police are in both, deportations happen in both. And this hit me most heavily a number of times, and one is which after the killing of George Floyd in 2020, when there was protests in Minneapolis, there was video footage shared of the protests collected by law enforcement who used the Border Patrol drone, right? So they flew a Border Patrol drone from probably Texas, right, up to Minneapolis to videotape or to record the protests going on. And the second was the home raid that I covered that resulted in multiple deportations was perfected, right, was done over and over and over again in Black communities, right, for very similar reasons because of the war on drugs. But these tools of deportation, incarceration are perfected in one community and then brought over to the other, right? And I see it happening all the time. And it just makes me think about what, the work that we need to do to illustrate how these deportation, immigration, and prison incarceration systems are just different sides of the same carceral state issue. The last thing I'll say, and I'll leave talking about the syllabus and classes and teaching till a little bit later. We worked on an AJPH paper about it was something. So when the pandemic happened, many academics and researchers had to stop writing papers on data, right? Projects had to close, we weren't collecting data. So you began to see this rush of public health people like yelling and being mad. And it was a beautiful moment for us. Like we were all doing these commentaries and editorials. And ours was like, we got to close these effing detention systems because everyone's going to get COVID-19, right? And we traced the reasoning behind this. And as the first speaker, as Omid said, these places are not made to be healthy, safe places. And it felt like the most obvious argument in the world, but it was like, look, these are places where space between people is minimized so that they can be forced into a certain small square footage so that as few people as possible can oversee them. And one of the things that really drew the comparison between immigrant communities and incarceration is where these outbreaks were happening. And one was in prison, and one was in meatpacking plants, right? Often in which work is so condensed. Often the laborers are undocumented or African American, especially in the South. But the whole point of these meatpacking plants is to pack people as close as we can, to observe them and exploit that labor. Exactly the same goal as the prison system, right? Pack bodies of color as close as possible to exploit, often for labor purposes. So this really pushed me to think, like, how do we link these systems? How do we learn to talk about them and teach about them at the same time? Thanks so much for having me again. Honored to be on this panel, and I'll turn it back to Christine.
Thank you, Dr. Lopez. Yeah, and thanks for drawing those connections that I think are really important between policing, between deportation. Yeah, the idea that all cages are connected. So going to hand it off to Maria Thomas, and reminder to you all that you can stick questions in the chat at any time.
Thank you, Christine, and just thank you to all of the organizers, those working behind the scenes to put this on, and gratitude to all of you for showing up and being committed to building the world we need. And I just want to express just thanks for all of the comments that have been raised so far. Omid, I really appreciate what you said about the connection to anti-imperialism and how abolition has to be an international project. What I think, and this has a particular resonance for me personally. I live in Washtenaw County as well. Bill and I are practically neighbors, but my life has been trisected between South India, where my family's from, the so-called Middle East, and the American Midwest. And I was displaced by war as a child. And so when I think about abolition as the fight against prisons and policing, I also factor into that violence, the global policemen, the military. And we need to be fighting on that front as well. And so when we chart the history of what's happening in Iran, we also have to be fighting against all manner of intervention, from CIA coups to crushing people's movements across the world. And fights for bodily autonomy in Iran are connected to fights for bodily autonomy everywhere. We're seeing fights in this country around abortion care criminalization and gender affirming care criminalization. Again, fights that are very much fights of bodily autonomy that target populations that have long been pathologized and criminalized by public health and medicine. And Michael, thank you so much, and wishing you so much health and protection as you fight in the most difficult of circumstances. I'm so grateful for the organizing you're doing and the way you are providing care and modeling that, even in the face of supposed medical providers telling you not to. So again, for the students gathered on the call, I also just want to remind everyone that those of us in the free world have an obligation to be in community with and follow the lead of the folks inside. And I'll drop this in the chat later, but there are 9 commitments from Mariam Kaba, one of the amazing organizers and visionaries that I have the privilege of being able to be part of an organization with, that I'll drop in the chat, about how we can be in solidarity with folks inside. And to the point about all of the repression and things that incarcerated comrades are facing, I want to uplift the fact that in Alabama, there is an ongoing strike, and ADOC there is trying to starve people out of the strike. And if you follow on Twitter, the Free ALA movement, you can get more information about what those demands are. And Bill, so before I launch into like what the work of Beyond Do No Harm and interrupting criminalization is, I also want to just shout out to Bill for just reminding us of the wins we can create together when we organize together. And thank you for that reminder of our collective power and to keep our eyes on the world we're trying to create. And I'm glad I get to work with you in different spaces in Washtenaw County as we're trying to figure out what non-police crisis response looks like, and all the other things that, that speak to this idea of abolitionist presence. What are we trying to build? What are the networks and systems of care that we can together create? So Interrupting Criminalization, the organization that I am a part of, is an initiative led by researchers Mariam Kaba and Andrea J. Ritchie. And the project aims to interrupt and end the growing criminalization and incarceration of women, of LGBTQ people, of color, for criminalized acts related to public order, poverty, child welfare, drug use, survival, and self-defense, including the criminalization and incarceration of survivors of violence. And within that umbrella organization of Interrupting Criminalization sits the work that I am so honored to help coordinate, and that Christine is part of, and so many people I admire and respect so much. And it is called the Beyond Do No Harm Network. Just wanting to make sure that I'm not missing anything critical in the chat. Okay. And what the Beyond Do No Harm Network is it is a group of advocates, of health practitioners, of directly impacted folks, all of whom understand that accessing medical care is a huge site of criminalization. So we are cross-movement folks working on reproductive and healing justice, trans liberation, migrant and disability justice, and against family separation and family policing and so-called child protective services. And what we are trying to do is to address and interrupt the harms created when health providers, institutions, public health researchers, and different kinds of medical providers facilitate, participate in, and support criminalization. And we see this happen all the time. And we also know that medicine and public health have a long history of pathologizing and criminalizing marginalized populations. In fact, if folks want to just to have a little bit of interaction, drop in the chat some of the ways that you see and you confront and grapple with how our fields do this. How are we criminalizing folks as they are seeking care in the very places that they are seeking care? I'd welcome any kind of input from your vantage point. But as you're mulling that question over, yeah, absolutely, calling 911. Security guards in healthcare waiting rooms, right? Why on earth are cops in healthcare facilities? It's a recent phenomenon. They have absolutely no business being there or anywhere, right? It is antithetical to care. It is antithetical to healing to have these agents of the state there and providers facilitating the criminalization of patients by administering unconsented drug screens and drug tests and warrantless seizure and search of property. I mean, there are so many ways in just having cops on campus can funnel more and more people into the prison industrial complex. Wellness checks by police. Yeah, so these are such brilliant and kind of astute examples of precisely the points of intervention that we are trying to seize through the Beyond Do No Harm Network. So, you know, we see pregnant people as undergoing so much surveillance. This is always true, but it's increasingly escalating to a point where pregnancy outcomes, miscarriages, and of course, self-managed abortions and self-managed care of different kinds are being criminalized. We see people who are using drugs being criminalized. We see immigrants being criminalized because they don't have a certain kind of paperwork. So there are all of these ways in which people accessing medical care are criminalized. People in the sex trades will often be stigmatized and criminalized. And of course, you have police and deputized as police healthcare providers acting as agents of the state, facilitating those forms of criminalization in hospitals, in clinics, in public health spaces. And so what we in the Beyond Do No Harm Network have done over the last 3 years is to develop a set of principles that we're inviting medical providers, public health researchers, and public health workers to sign on to around non-participation in facilitating and condoning criminalization. And we feel that it is such an important site of struggle. In fact, I'm going to share the screen so that you can take a look at the principles without my having to read out each and every one of them, but I do want to highlight some of the ones that you have already surfaced in the chat and through presentations, through the comments that all of the panelists so far have made. So let me do that. Thanks for making me co-host. All right. You all able to see that?
Yep.
Oops. That's not what I meant to do. Okay. So we have end police and ICE presence in hospitals and in or near healthcare facilities. Somebody mentioned security guards and private police forces. The fact of their presence itself just means that there are more encounters and there are more fabricated reasons to criminalize people seeking healthcare. And we believe that it's also necessary to stop this kind of healthcare surveillance system that is also used to criminalize targeted folks. So we want providers to commit to these principles and to end this practice of calling police on folks with unmet mental health needs, folks who are grieving, and folks who may be in position or distributing or using drugs. And we want the principles of patient confidentiality and informed consent to be honored. And that isn't the case when there is all kinds of screening and testing that happens without consent, which we know happens in hospitals. And mandated reporting is another way through which poverty is often codified as neglect and families are separated. And then we want to make sure that providers are brave and bold and refuse to support prosecution of all manner of things, whether it's folks administering hormones in their community because they don't have access to formal networks of care, or they're managing unmet mental health needs in different ways, underground sort of networks of informal care. All of those things are criminalized, and we want providers and public health workers to stop supporting prosecution in all of these cases, including cases of drug use and overdose and conspiracy charges related to that. And then to Michael's point, all healthcare and medical care that happens in carceral facilities is often violative and coercive, and there's so much rampant neglect, as Michael illustrated so powerfully. And so we believe that while we ensure that folks inside have the care they need, we also need to be focusing on decarceration, because you cannot get well in a cell. And freedom really is the only treatment. But we want to ensure that there's whistleblowing in terms of substandard violative care for folks who are in custody. And we absolutely want to make sure that there's no collaboration with the criminal and punishment system, so that providers aren't evaluating whether people are competent to stand trial and to be put to death. So there's a whole range of principles. We'll be releasing them publicly. This is a sneak peek for all of you before our public launch event on November 3rd, which you're all invited to, and you'll get to hear from Christine and other brilliant folks who help develop these principles. And I think I'll stop there. But thank you so much for the opportunity to share, and I look forward to just any questions you may have.
Thanks, Maria. Thanks for sharing those principles. Excited for the launch. Cool, so let's move into Q&A, and I'll throw out a first question. We have a few that are coming in the chat, but let's start with the first question. So this is for all of you. What would you like to see the field of public health take on with regards to abolition? Maybe we can go in the same order if you want to start, Omid.
Well, I think depending on where you sit, right? So I think within the public health space, you're wearing a health department hat, you're wearing a, nonprofit hat. There's a lot of institutions that the public health consists of. And I love everything Maria just shared, in particular those principles, because I think I think putting the burden on ourselves, especially to not only just learn how to apply it, but to actually bring it in. How does it uniquely fit into what we're doing? So those principles, I think, for example, and things like that is a great example of how we can apply it really in any facet of public health work. If we're thinking about giving people what they need, we can get very far in controlling the narrative of how we are talking about issues, how we are framing issues. And I think that looks different for each of us. So I would really like the narratives to start to continue to change. I think we've seen a lot of that since uprisings in 2020. The system, the way the status quo will always pull the inertia towards the harms that we're familiar with. So I think it is on us to say it, repeat it, put it on the agenda. And yeah, I think controlling the narrative for me right now is just resonating the most, and what I think each of us have a piece of the puzzle of to do and control.
Well, I'm going to toss it to you next because Michael's going to have to call me back.
Sure, thanks. Yeah, so thinking about what we want schools of public health to do, I think one obvious one for me is that I think more schools of public health should teach about the incarceration system. I jotted down the statistic that we all know. We have 20% of the world's prison population, but 5% of the world's population. Like, it's just astronomical how many lives are shaped by being in a cage. And that's not counting all of the people connected to them. Yet, generally speaking, there's not this class in public health, right? It just doesn't happen. And I think it's time to change that. The second is, in addition to speaking specifically about the incarceration system, perhaps as a class or as a social determinant of health, I think we need to start working incarceration, excuse me, and law enforcement into many of our classes. So many professors are like, I'm not an expert in law enforcement or the prison system, so I'm not going to talk about it. But we talk about education, we talk about cancer, we talk about smoking, we talk about all kinds of things, right, that we're not experts in, that we draw from the public health perspective for these things to teach about them. And it's time to start doing that with policing and incarceration, largely thanks to you, Omid, for as you said, putting all that evidence base together in the public health APHA statement. Christine knows I'm such a big fan of that statement. If I were physically present with you right now, I would print it out and have you autograph it. I use it so much.
Love that. Cool. All right. Michael, do you feel ready to answer that?
Yes. So the first thing I would like to point out is that we all know that the age of the prison population is only getting older due to the long sentences handed down during the age of mass incarceration. And by some accounts, 40+% of the prison population is over 50 years old, and there are many senior citizens in the facilities throughout the country. One of the main things that I would like to see people in public health do is try to put an initial push to have each Department of Correction put back in the hands of Health and Human Services and throughout the entire country, because that would bring back some humanity and some benefits to help individuals who suffer from mental health issues, physical health, and environmental factors. Being that the DOC is primarily a militarized organization, that when the transfer was put in place from Health and Human Services in most states, they ended up getting more money to pad their stats and to pay more correctional officers and overtime. Right now, in Massachusetts particularly, they have decreased the population of the prison almost in half. So it has to be commended that they did that, but yet still they take such a huge hit against the tax budget that COs are now scamming the system, working a lot of time and getting paid a lot of money to basically to do nothing. They wasting taxpayers' money where it could be be allotted to other things such as taking better care of the health population. So kind of the main point is that, and I reiterated it, is that every department of correction and the prison population needs to be placed back into the hands of Health and Human Services throughout the country, and that's the big public health issue that I think needs to be addressed right now, and also that people in public health, such as yourselves, that are studying and learning to create new public health policies, like get in touch with people that are incarcerated. Like we err on the side of caution because everybody's not doing the work of abolitionists, but find organizations and people who are doing the work so that they can share their stories with individuals that tug, for lack of a better term, tug at the heartstrings. I know my sister well enough that Christine, that when I read this, she got a little bit emotional, and I hope you don't mind me saying that, sis. But at the same time, it's necessary for people to understand what the condition is in these places, and I'd like to yield my time with that.
Thanks, Country. Maria, anything you want to add?
Thanks, Michael. Thanks, Christine. I mean, I think echoing some of what's been said before is I just like the field of public health and the field of medicine and all health allied fields to say with their whole chest that public health requires abolition. And public health must be explicitly anti-racist, internationalist, anti-imperialist, abolitionist, and anti-capitalist. And I so appreciate the statements as well. I use it all the time. I will be in queue behind Bill. But I mean, it's just true. The public health cannot exist as long as the carceral state, prisons, police, global police, the military, detention centers, and criminalization exists, because all of these things are completely antithetical to healing, to care. And they make us and our whole society sicker, more atomized, more alienated, more violent, more precarious, and more poor by design. And yeah, I would just like that narrative of public health requiring abolition as a prerequisite to become the common sense narrative. And the fact that medicine and public health are inherently political. There's no like bullshit objectivity, right? We have to lean into being on the side of justice and fighting for that and naming our values.
Yes, amen. Thank you. Cool. Okay, we got a bunch of questions coming in, which is awesome. We have a couple questions from students that are sort of similar, so I'm going to put them together, but feel free to answer different parts of this that are about how to build trust with communities as students. So being grounded in community organizing, getting connected with organizers in the community around their institutions. I think it's sort of how to logistically do that to build trust when students are not there for very long. And then also ideologically knowing that the academy is often antithetical to doing this type of work. Whoever wants to take that.
I'm happy to kick us off. One, I think of, another key tenet of public health is community-based public health work, right? And so community-rooted, community-led, whatever you want to call it, but the fact that public health requires that we also partner, collaborate with community as our key way to do research, as our key way to do any public health practice, I think is one entry point for us ultimately. And I can reflect back on being in school as well during, a 2-year program and thinking about, what are my goals? What are the academy's goals? And what is the community's goals? And where does that overlap? And even in those 2 years, I know that there's X, Y, and Z that I have to do. But that doesn't have to be antithetical to what the community wants, in fact, especially if we're putting relationships first with the community. Because after 2 years, I'm gonna be not wearing that student hat anymore. But my ability to still be connected with the work, be connected with community, is going to be based on those relationships. There are way more ways to get through graduate school than I think academia initially presents to us. I think it is on us to build new pathways, especially leaning with those values of public health, to make sure that we can still spend those 2 years, we can still build relationships with community, and at the same time, challenge institutions within and do what we need, just so we can also then take what we need from that institution and then continue to do the work that we want to do.
What Omid said.
Yeah, I'm happy to add just one or two things. I think that was great. I want to echo, if I'm hearing you correctly, Omid, that geographic links are only one kind of link. So remember, we live in an organizing world that is often online or is often movement based, right? And you will move throughout the country, linking up with the people of the same movement. So I encourage you not to think about your geography as a limit, but as an opportunity to plug into more networks that may be, throughout the country, if not the world. The second is start using these themes, bring in abolition into much of your public health assignments, right? Just start working on doing the research. You have to often pick a topic for your term papers. Try writing about these topics. And the third thing I would say is, this is going to sound funny, but take the minimum amount of credit required and use your time to do some organizing, right? So oftentimes we're lots of type A people and we get into this program and we think the way that we do our best is to fill our time to the nth degree by taking 21 credits. There's people out there who do that, and that's great if that's what you're choosing. You can also take the minimum and spend your time elsewhere, right? In the community oftentimes. And one of the things that I found helpful during my graduate school time was really just to have a hard conversation about which fights were my fights. There are plenty of fights to fight. I chose at that time not to do a lot of the organizing that was going on campus. I'm very thankful that other people did. And I chose instead to do organizing in the immigrant community in Washington County. And that was a very conscious choice, right? We can't work in all movements. And, I encourage you to feel liberated in investing your time in one that you think is valuable and not spreading yourself so thin that you can't build relationships or dig into that movement.
Thank you all. Michael, do you want to add anything?
Yes, I just briefly like to say that trust is not a sprint. Trust is a marathon. And when we're talking about trust and building of communities and building of abolitionists and building of safe containers for us to work in, we first must make a deep-rooted effort at introspection. And I say that because if we're going to be involved in this work, we have to be involved with it with all of our heart and all of our caring, and then the trust comes into play. Without that, if this is a whim for individuals, it may not be for you, because as I've built relationships doing this work, a lot of individuals were students, including myself at the time, but we built enough trust and community to where, sometimes we may disagree with one another, but we always find common ground and find common trust that we have each other's back when we're called upon. So, and one of my favorite quotes is from Dr. Martin Luther King, and he says, our lives begin to end the day we become silent about things that matter. If abolition is something that matters to you, don't be silent about it and don't be scared about it. To build trust with others so that we can constantly build our community to tear down the systems that were built and aim to do what all of our principles guide us to do.
Thank you. Awesome. Okay, so maybe let's do one more question. So this question came in, which is, do you believe that the present infrastructure of healthcare can continue to exist in an abolitionist world? So it's sort of a similar question about the design of the academy being neoliberal, carceral, white supremacist. And how do we move beyond political education to actually helping communities take back power?
Well, I do think radical transformation needs to happen. Hospitals, healthcare, for-profit, these are all highly carceral institutions. And I think there needs to be a commitment from folks within to refuse to participate in harms while also building our capacity outside of these institutions to radically reimagine and practice being in different ways of relationship with each other and having different communities of care and networks of support predicated on mutual aid and other principles that have a long lineage and history that we can learn from and continue to build on. But yeah, we're not looking, I mean, our project is not to kind of rehabilitate the reputation of healthcare systems. And it's like not again, just like we're not trying to reform the PIC, we're not really trying to reform hospitals. We're trying to provide affirming care in all of the spaces that we can and to interrupt harm and criminalization in all of the ways that we can, while building and dreaming something much, much bigger and much more expansive than healthcare as it exists today.
Yeah. Anyone else want to jump in on this one?
Yeah, I'm sitting with this question because I think it's a really good one, and the use of the word healthcare I'm thinking about too, because when I think about public health, I remind myself that the fact that I even have a job, that there is this field, is because of the harms that exist. And so if that was my framing, then I would think that if we are going back to that quote, if we're thinking about the presence of housing, the presence of healthy foods, the presence of healthcare justice, et cetera, then things should fundamentally look absolutely different. And I couldn't even say exactly what that world alone myself should look like, but I know it does require the presence of all those basic needs that we all need to be in community with each other, and that any of us would consider to be associated with health. And yeah, and I think, the practice is important. Living it is important. Teaching is important. I think the political education can be a driver to how we actually bring it into fruition. But quite literally, every day we either make decisions or we are a part of decisions, and those are all opportunities for us to think or move differently. And I think being organized also includes taking that aligned political education and then doing that same practice on those many decisions each day. Some will be big decisions and those will feel harder. But I think it's us all collectively and cumulatively doing that. Yeah, that's what's sticking out to me right now. But I think that is a great question, because we do need to ultimately know where we're going, what we're building towards.
Yeah, I think I'll add one more thing, if that's okay, Christine. So I like this question, Jess, and I might be projecting. I read a little bit of discomfort in it, right? Like, do we have to really change this whole system? It seems expansive and difficult to do. And one of the things I always like to remind folks is that if we are only able to do public health work when we're confident of ourselves and sure in the direction we're going, we'll never be able to do abolitionist public health work, right? So even amid despair, even amid confusion, and even amid unclear vision of where we're going, we're still able to draw on public health research, and we're still able to do evidence-based work. That's not an answer to your question. I just like to remind folks that, like, yeah, this is hard, exhausting work, and we can do it while being exhausted.
Country, anything to add? All right. Cool. I just want to answer a couple logistical questions that popped up in the chat. That yes, we will be sharing all the links that were shared in the chat in the follow-up along with the recording. And if you are interested in being a more formal part of the network and joining these small group discussions, that'll be weekly. You can send me an email. I'll stick my email in the chat just so that I have your email. Most of you, I think, check this off on your registration form, but if you didn't, you can just send me an email there. Cool. So I want to thank you, Omid and Michael and Bill and Maria, just for all of the incredible and expansive insights and expertise that you shared with us today. I think I'm definitely like taking away a lot that I'm going to be thinking about. So I really appreciate that. And this just feels like a really great kickoff for this iteration of the network. So thank you for that. And I also want to thank—
You have 1 minute left.
I want to thank our live captioner. Thanks for being here and captioning all of this. I know it was fast and furious
The caller has hung up
at a few points. So super appreciate that. Thank you to Amber for putting stuff in the chat and generally helping manage things, and Steph helping to manage slides and DJing and all the things, and also just helping shape and form what this network looks like. And then just so you know, the next session is going to be on Wednesday, October 12th, same time, same place. And that session is going to be focused more on building some organizing skills. So it's going to be a few different things, including power mapping, and then how to have a one-to-one with someone who might be a potential ally in your organizing. And then finally, I just want to say those who did opt into being a formal part of the network, keep an eye out for that email that I'm going to send later today. And those groups will kick off next week. So please be sure to check that out and fill out the action items that are in that. And that is it for now. Thank you all for joining us for this, and looking forward to seeing you either next week for the small sessions or at the next session on October 12th. Thank you all. Thanks, team.
Yeah.